Thank you, Allie. We recognize there's been a lot of activity and communications from the board on various initiatives, so we wanted to remind you of some of our latest initiatives and provide you with a few new updates. We also want to give you an opportunity to ask questions at the end of today's presentation. So today we will start with brand new updates on telehealth regulations, followed by updates regarding disability benefits and the new workers' compensation maximum weekly benefit rate. We will then look at OnBoard, the board's improved business information system, followed by the New York Medical Treatment Guidelines, or MTGs, and some reminders regarding the CMS 1500 form. We will also review important information about workers' compensation as it pertains to COVID-19. And finally, we would like to remind you of some things when submitting first report of injury or FOI filings, and we will review the additional resources available to you. And then we'll leave time at the end of the presentation for your questions. So first, some big news. As of July 11th, telehealth is now a permanent part of the New York State workers' compensation system, following the adoption of a regulation that was many months in the making, with several iterations and rounds of public comments. We're very happy to now have this in place, but I'll briefly share how we got here and what it means. In New York State, telemedicine was an option before COVID-19, but was limited to phone calls to discuss test results in lieu of an in-person visit and within a finite time window. During the pandemic, emergency telehealth regulations significantly increased permissible uses of telehealth on a temporary basis to ensure continuity and access to care. Emergency regulations were extended multiple times. A 2021 study by the Workers' Compensation Research Institute found that telemedicine is changing the way healthcare is delivered on a national level. As of the first quarter of 2021, use of telemedicine for evaluation and management, or E&M services, was still higher than prior to the pandemic. However, post-pandemic, physical medicine visits have returned to near pre-pandemic levels. Costs for services that were delivered both via telemedicine and in person were generally similar. The number of visits per patient when telemedicine was present, relative to only in-person care, was larger when follow-up visits were a mix of telemedicine and in-person services, and smaller when all follow-up visits were delivered exclusively via telemedicine. The board's permanent telehealth regulations have gone through several iterations with extensive stakeholder input, and the new permanent telehealth regulations took effect July 11th, 2023, following the expiration of the last set of emergency regulations. So now let's dive in on some of the details surrounding this new permanent telehealth regulation. The newly enacted New York State regulation states that telehealth appointments may be performed by physicians, podiatrists, psychologists, nurse practitioners, physician assistants, and licensed clinical social workers through two-way audiovisual or audio-only communications. The provider must also be available for an in-person visit within a reasonable travel time if necessary. An in-person visit may be required as may be specified in the medical treatment guidelines or based on the clinical age and stage of the condition as follows. For MDs, DOs, DPMs, NPs, and PAs, the initial visit, every third visit for acute or subacute, every 3 months if chronic but not at MMI, and annually if chronic and at MMI. For psychologists and licensed clinical social workers, telehealth should be permitted for the first and subsequent visits, including group therapy, irrespective of clinical stage of the condition. Remote behavioral health visits should be limited to situations when there is no benefit to in-person services versus remote services, or when an in-person office visit poses an undue risk or hardship on the patient. The reason for the use of a remote telehealth visit should be documented with each use of a telehealth visit. Treatment may not be rendered via telehealth for chiropractors, acupuncturists, physical therapists, or occupational therapists. Telehealth appointments that have been scheduled prior to the effective date of this new permanent regulation do not need to be changed to in-person visits in order to conform to this regulation. and the use of telehealth should not be the sole basis for challenging the results of such visits. However, any appointments scheduled after the July 11th effective date must conform with this regulation. The regulations also delineate various clinical scenarios that indicate an in-person exam may not be necessary, such as routine follow-up appointments after a comprehensive initial in-person exam has already been conducted, or to discuss test results and/or counsel on clinical options. And when an in-person exam is necessary, such as to perform procedures, emergencies, eye conditions, nuanced or complex issues, etc., or when an in-person physical exam might reasonably impact the accuracy, quality, or certainty of the assessment, treatment, or recommendation. Some scenarios do require an in-person visit. They include, but are not necessarily limited to, urine drug testing, appointments to determine permanency, impairment or disability, initiation of a chronic medication, or if the patient lacks the technology, capacity, or the desire for telehealth visits. We are frequently asked whether independent medical exams, or IMEs, can be performed via telehealth. It should be first noted that technically IMEs are not considered treatment. With respect to performing IMEs remotely or virtually, this is permissible if all the parties agree, and as long as the IME is not being performed to determine permanency or permanent impairment. As I mentioned, these regulations went through several iterations, incorporating extensive stakeholder input, and we believe that the newly enacted regulation strikes an excellent balance of that input. The board has received inquiries regarding the proper method for payers to object to treatment via telehealth, in instances where the payer believes the use of telehealth was inappropriate and inconsistent with the regulation. When a payer believes that treatment by a physician, nurse practitioner, physician assistant, or podiatrist via telehealth has been provided improperly pursuant to the regulation, the fact that medical treatment was provided via telehealth should not be the sole basis for a legal objection to a bill for such treatment, and the services should be reimbursed unless they are such that telehealth is clearly precluded by the regulation. Example, an initial visit with a provider or visits to determine permanent impairment. In other more nuanced instances where the payer believes that medical services for physical injury or illness are being improperly rendered via telehealth, the services should be reimbursed, but the payer may request that future similar services be conducted in person by filing a request for further action by insurer or employer, Form RFA-2. The payer should check box K and request a direction for a future in-person visit in accordance with the regulation and state why the visit should not be performed via telehealth. If a board order to conduct a specific clinical service in person instead of via telehealth is ignored or otherwise disregarded by the provider may be subject to administrative action. The payer should not file a notice of objection to a payment of a bill for treatment provided, Form C8.1B. The filing of Form C8.1B in these instances will be found moot. Treatment rendered by chiropractors, acupuncturists, physical therapists, and occupational therapists under the New York Workers' Compensation System may not be rendered via telehealth. When a payer believes that treatment has been improperly provided via telehealth by one of these provider types pursuant to the regulation, the payer may file Form C8.1B with the other box checked and noting in the description that the provider type is not permitted to perform medical treatment via telehealth. We wanted to remind you of updates regarding disability regulations, which were adopted in April of this year. In keeping with the goal to make it easy for workers to receive compensation they are entitled to, the Chair adopted amendments to Sections 355.4, 363.1, 363.11, 363.13, and additions of Sections 363.15 and 363.16 of Title 12 to update and clarify the disability benefits regulations and disability benefits claims process, conform the regulations to the statute, and align several sections with paid family leave. The Notice of Proposed Rulemaking was published in the October 12, 2022 edition of the State Register. The Notice of Adoption was published in the May 10, 2023 edition of the State Register, and these changes will take effect on January 1, 2024. The Board is currently in the process of updating the disability forms, creating new forms where appropriate, and updating the Board's website. The updated forms will be available by late fall. To read more about these updates, visit the Board's website at wcb.ny.gov and select the Regulations link on the bottom left of the homepage. You will find the link at the top of the Adopted Regulations section on the next page. The maximum weekly benefit rate for workers' compensation claimants is 2/3 of the New York State average weekly wage for the previous calendar year, as determined by the New York State Department of Labor. The Department of Labor reported to the Superintendent of the Department of Financial Services that the New York State average weekly wage for 2022 was $1,718.15. Accordingly, the maximum weekly benefit rate is now $1,145.43 for compensable lost time for workers' compensation claims with dates of injury during the period from July 1, 2023 through July 30, 2024. By now, payers should be familiar with our business information system, OnBoard. OnBoard Limited Release, the first phase of the system, was implemented in phases from March 7, 2022 through May 2, 2022, beginning with submission of prior authorization requests, or PARs, for medication, known in the system as medication PARs. Today, providers and payers are using OnBoard to request and review prior authorization for medication, durable medical equipment, and treatment and testing, and we have hundreds of these PARs successfully flowing through the system each day. To date, more than 47,000 payers and reviewers have signed up for access, and nearly 960,000 PARs have been processed. We are truly working to take the comp out of complicated. As a reminder, payers will need to log into the medical portal to access OnBoard. Every user will need their own login credentials. A single login cannot be provided to an organization to be used by all users who are part of that organization. There is no limit to the number of users an organization can have. Claim administrator access for insurer, self-insured entity, or third-party administrator is granted using organizational profiles based on eClaims trading partner information. The payer is ultimately responsible for the review of PARs. A payer may designate a medical review organization to review their PARs. However, the medical review organization must first complete the online medical review organization medical portal registration. Pharmacy benefit managers, or PBMs, may be designated by the payer to review Level 1 medication PARs. The PBM must complete the online PBM medical portal registration process prior to a payer designating them as the reviewer. This chart outlines what submissions each provider type can make in OnBoard. For example, all provider types listed can submit a request for decision on unpaid medical bills, Form HP1, non-MTGs under or equal to $1,000 PARs, and non-MTGs over $1,000 PARs. You can review this chart on the Payer Overview page at wcb.ny.gov/onboard. Once a PAR is submitted, you, the payer, have a set number of days to respond. Response requirements vary for certain PAR types. Responses for MTG confirmations are required within 8 business days. Responses are not optional. MTG variants and MTG special service responses are required within 15 calendar days, but the response time is extended to 30 days if an IME is requested. Non-MTG over $1,000 responses are required within 30 calendar days. Non-MTG under or equal to $1,000 responses are required within 8 business days, and medication and durable medical equipment responses are due within 4 calendar days. These timeframes may vary based on weekends or holidays, depending on when the PAR is submitted. Please note, if the wrong PAR type is submitted by the provider, it is appropriate to deny the PAR and mention why in the comment section. For example, a confirmation PAR was submitted when a special services PAR was required. If the provider wants the service, they should resubmit as a special services PAR. You can also view this chart on the payer overview page at wcb.ny.gov/onboard. Rather than release OnBoard all at once as a large-scale initiative, the board plans to develop the OnBoard system improvements as a series of smaller, discrete projects that will be released incrementally. The system upgrades will use web-based platforms and electronic data, increasing our ability to enhance these systems over time. We expect that this approach will enable the board to be more responsive to stakeholder feedback over the course of this multi-year program. Currently, the board is advancing the OnBoard program by focusing on 2 key areas. The first area of focus is the board's expansion of the use of e-forms and the development of APIs to streamline data submission. The paper versions of the Request for Further Action, Form RFA-1LC, and Request for Assistance by Injured Worker, Form RFA-1W, are transitioning to an e-form with an intelligent online submission and routing process, although the paper-based process will still be available for injured workers who need it. The new process will be wizard-based, meaning it will walk users through fillable fields of a new e-form. The wizard will provide numerous fields for attorneys to enter pertinent information, allowing for quicker, more efficient board processing and response. Additionally, attorneys will also have the option to submit Form RFA-1LC via an Application Programming Interface, or API. APIs enable independent computer systems to talk to one another and exchange data, automating processes and reducing the need for stakeholders to manually enter data into web-based e-forms. When used correctly, APIs will be transformational in terms of providing faster, more efficient workflows compared to current paper-based form processes. The schedule for these efforts is in development, and the board is committed to keeping stakeholders informed as our planning efforts progress and a timeline is available. The second area of focus involves the collaboration of various board divisions to formalize future processes and requirements for the new OnBoard system, in addition to engaging our external stakeholder community. Understanding all processes and requirements will help us design and build a more intuitive, user-friendly system that benefits all board stakeholders. We are excited about these OnBoard initiatives and look forward to sharing updates on our progress in the coming months. Another area of improvement for the board has been the recently updated New York Medical Treatment Guidelines, or MTGs. For those who are new to these webinars or to the comp system, we'll give you some background. In December 2010, the board implemented legislatively mandated medical treatment guidelines, or MTGs, that fundamentally changed the delivery of healthcare to injured workers. The MTGs initially included 4 evidence-based guidelines for the treatment of injuries involving the neck, back, shoulder, and knee. These became the mandatory standard of care for dates of service on or after December 1st, 2010. On March 1st, 2013, the carpal tunnel syndrome MTG and updated versions of the then existing MTGs, including a new maintenance care program, were adopted. The non-acute pain MTG, as well as updated versions of the existing MTGs, were implemented for dates of treatment on or after December 15th, 2014. The MTGs effective for treatment as of May 2nd, 2020 are listed here on the slide. Please visit the Medical Treatment Guidelines section on the provider page of the board's website for more detail. The board has online training available on the MTGs for both medical and non-medical professionals. Payers should complete the non-CME versions of each training. To access them, visit the board's website at wcb.ny.gov and navigate to the Healthcare Provider section in the middle of the home page. Select the Medical Treatment Guidelines link, and from there, select the training link on the right side of the page. As the board continues modernizing and improving stakeholder interaction with our systems, we look back on our official transition to the CMS 1500 form, the Universal Medical Billing Form, 1 year ago. Since July 1st, 2022, more than 6 million CMS 1500 forms have been submitted, including 1.4 million electronic submissions through an XML submission partner. More than 10,000 providers have submitted their CMS 1500 forms electronically through an XML submission partner. The board transitioned to the universal form to reduce the administrative burden on participating providers who previously had to use separate board-specific forms for their workers' comp patients. Since July 1st, 2022, healthcare providers have been required to use the CMS 1500 for all workers' comp medical billing. Electronic submission through an XML submission partner is strongly encouraged, although not currently required. As part of the initiative, use of prior medical billing reports, including Doctor's Initial Report, Form C4, and Doctor's Progress Report, Form C4.2, have been discontinued. Payers are required to use the new Notice of Treatment Issue Disputed Bill, Form C8.1b, and Notice to Healthcare Provider and Injured Worker of a carrier's refusal to pay all or a portion of a medical bill due to valuation objections, Form C8.4, with applicable Claims Adjustment Reason Codes, or CARCs, to object to medical bills. Workers' compensation payers will electronically transmit EOBs, or EORs, to their XML submission partners upon adjudication of the associated electronic CMS 1500 medical bills. Please note, provider types who are not permitted to opine on causal relationship or level of impairment are not required to submit this information. The board has developed a medical narrative report template that can be used to create the medical narrative report that accompanies provider submissions of the CMS 1500 form. Providers should use this report when submitting the CMS 1500 form. The board strongly encourages providers to include the 3 elements, causal relationship, work status, and temporary impairment in every clinical note, because that information is so frequently essential to the seamless administration of claims. There are several instances, however, in which this information is not as critical to the payer or the board, and it is not needed to properly adjudicate the medical bill. One example is a claim in which the injured worker has reached maximum medical improvement, or MMI, and a permanent partial disability, or PPD, classification has been made. Moreover, certain provider types are not permitted to give formal opinions on causal relationship or degree of impairment. For full details, please see the WCB authorized providers who can do what chart on the board's website. In a communication dated November 18, 2022, payers were notified that they should not routinely file Form C8.1b to deny payment to healthcare providers solely based on the absence of one or more of these 3 elements. Such legal objections may be resolved in favor of healthcare providers if this is the sole basis for the dispute, and the information is deemed by the board to be present, clearly implied, or not critical to the administration of the claim at the time of the clinic visit. If a payer objects to a bill, the legal objection that was filed must be resolved first. If the bill is still not paid after it has been resolved in their favor, providers can file Form HP1. Please note the CMS 1500 initiative does not change anything related to a payer's assessment of causal relationship. It merely informs providers that causal relationship is to be reported prominently in the medical narrative. A PDF of the report, as well as a chart listing medical narrative report requirements by provider type, can be found at wcb.ny.gov/CMS1500/requirements under the Medical Narrative Requirements section. We urge you to share this template with providers if you notice it is not being used. More information on the CMS 1500 initiative can be found on wcb.ny.gov/CMS1500, or you can email cms1500@wcb.ny.gov with questions. Effective July 1st, 2022, payers are required to use the updated Form C8.1B and Form C8.4 to notify the board of legal and valuation objections. Also, payers must use the same CARC and BART codes on EOB or EOR sent to providers. Updated versions of Form C8.1B and C8.4 can be found on the Form section of the board website at wcb.ny.gov. There are 4 scenarios when you should not be filing Form C8.1B or Form C8.4. When the amount billed for a CPT code exceeds the amount designated by the applicable medical fee schedule, and the payer pays the bill at the medical fee schedule amount, the payer reduces the amount of the bill to 12, 15, or 18 relative value units for evaluation services and modalities as set forth in the applicable medical fee schedule. If the payer reduces the amount of the bill pursuant to a contractual agreement with the provider, for example, network or PPO discount, or if there is a duplicate bill. The reason for payment reduction or non-payment if a duplicate bill should be set forth on the EOB. As you may already be aware, workers who believe they contracted COVID-19 in the workplace may be eligible for workers' compensation benefits. As payers of workers' compensation, you provide crucial benefits to both employees and employers. The employee receives the lost time and medical benefits stemming from a compensable claim, and the employer has a peace of mind knowing its insurance coverage will ensure that employees are covered. We strongly encourage you to be proactive in distributing information about how to file a COVID-19 claim. Employees should be encouraged to file a claim if they feel they contracted COVID-19 at work. You should also encourage employers to help employees file claims and remind them it is illegal to take any disciplinary or discriminatory action against employees who file or wish to file a claim. Please review all claims carefully and timely, even if a medical report has not been received. More information on COVID-19 and workers' compensation can be found on our special COVID-19 section of the website, which is at wcb.ny.gov/COVID-19. Lastly, the board would like to remind claim administrators to ensure timely filings of first report of injuries, or FROIs, and to properly notify the board of the correct claim administrator. This will avoid untimely filing penalties assessed by the board's monitoring unit. This also helps provide accurate information to OnBoard, ensuring PARs are given to the correct administrator. As we continue to work on implementing improvements for payers, we're committed to the following: increased communication with payers, such as this webinar and targeted emails. The board also has a special webpage for payers. Visit the board's website at wcb.ny.gov and select the payers link at the top of the page. We will be expanding the content on this page by creating a What Payers Need to Know briefing page that highlights key activities, much like we've done today. We also plan to continue engagement with all of our stakeholders, including payers, as the board continues its modernization efforts via the future expansion of the OnBoard system. For more information on OnBoard, please visit wcb.ny.gov/onboard. Resources include a walkthrough of the registration process, video tutorials, and recorded presentations for payers. For more information on the CMS 1500 form, please visit wcb.ny.gov/CMS 1500. We also have a dedicated mailbox to answer all questions on the CMS 1500 initiative, and you can email cms1500@wcb.ny.gov with those questions. If you have payer-specific questions, you can call the helpline at 877-632-4996. You can also visit our website at wcb.ny.gov and select the Payers link at the top of the homepage. For claim inquiries, please visit wcb.ny.gov/contract claims and submit your questions to claims operations. You can stay informed by subscribing to Get Board notifications straight to your inbox by visiting wcb.ny.gov and selecting Get WCB Notifications on the bottom of the homepage. You choose the topics you'd like to subscribe to. You can also follow the board on Twitter, Facebook, Instagram, and YouTube for board news, project updates, trainings, and more. Thank you for attending this presentation on important updates for payers. We will now take the rest of the time to answer any questions you may have.
All right, thank you, Jen. So as Jen said, we'll now open it up for your questions. As a reminder, please enter your questions in the chat box located on the right side of your screen. You will hear a brief silence as we take a moment to review your questions that have already come in. Thank you very much, and we'll be back.
Good afternoon. This is Audrey Cunningham from the Medical Director's Office. The first question is regarding the number of MTG confirmation pars that are really MTG variance pars. So in this instance, there are instances where the provider may genuinely believe that the requested treatment falls within the MTGs. So in that case, the denial of a confirmation par, because it should be another par, requires a clinical decision regarding consistency with the MTGs or not.
Hi, this is Paula from the Medical Director's Office. We have a question asking if a surgery request has already been granted in a PAR and a new PAR is received for the same surgery but with an additional CPT code, do we need to review again? The answer would be yes. They're asking for an additional code which was not previously reviewed, then yes, you need to review for that CPT code. Additionally, with this question, the inquiry is if you can use an administrative denial. The answer to that would be no, this is not an administrative denial reason from the drop-downs. You can only use what's there if it's appropriate. My suggestion might be if you've already approved it, you could certainly approve it again and reference the PAR ID number of the original approval, and that way it would not have to go to a level 2.
Hi, this is Barbie from Claims Operations. We had a question. Is an EOR or explanation of review attached to a CA.1B sufficient, or does the bill have to be sent with the form? If the medical bill is not in the board file, then the medical bill must be attached to the CA.1B. The EOR is not sufficient. Hello, this is Barbie from Claims again. There was another question. How do you cite on a CA.1B a procedure outside of the medical treatment guidelines if it's not specifically referenced in the medical treatment guidelines? In that case, a medical treatment guideline form would still be necessary. It would just be using the none code, so it could still be referenced in the CA.1B with that specific code.
Hi, there's a question with respect to getting clarity on whether or not an IME provider can do a second level review, especially if they've done an IME on the claimant in the past. And if the IME provider fits the definition of a carrier's physician according to the regs, they may perform a second level review. However, it's worth noting that opinions from two separate physicians, an IME and a level 2 reviewer, may be deemed a bit more compelling than the same opinion from the same physician, from a physician serving in both capacities.
Hi, this is Paula. We have a question. If a level 2 reviewer has a question for the treating physician, should they request the additional information to the portal, or should they make calls to the treating physicians? That's really either way would be okay. The system does allow carriers to initiate an RFI, request for additional information through the system, which is direct and goes straight to the providers. If you think that there is the possibility that you might want to be able to or might be able to approve something based on just a little bit more information, it would be in the best interest of the injured worker if you did reach out to them if you haven't received that RFI, but you're not required to.
This is James Wessel with Claims Operations. There's a question about the most efficient way to respond to the board when a case was assembled by the board and the carrier is alleging that the wrong carrier was assigned. The most effective way to do that would be to controvert the case with an 04, Froy or Stroy, and then that would trigger the board's processes, especially if you're, well, you would be controverting based on coverage, but that would trigger the board's processes to review that we have the correct employer and the proper coverage.
Hi, this is Paula from the MDO. I wanted to just say that we're getting quite a few suggestions of potential enhancements. Thank you for those suggestions. I wanted to let you know we won't be able to address each and every one of them in this session, but we will be taking these back to take a look at them and review them for potential enhancements in the future.
There are a few questions with respect to being able to grant without prejudice for an unestablished body part at level 1, and that is something that we have shared that we are working on as an enhancement. We just don't have a date at this time to provide, but we are working on it.
There's a question, if a level 2 provider in error submits the wrong response on a PAR, is there any way to get that PAR removed or changed? Thank you. I'm thinking that that was maybe a typo and it was meant to say if a level 2 physician reviewer submits the wrong response on a PAR. The answer is no. Once that decision has been submitted through the system, it's there. If you grant something, it cannot be reversed. It will stay granted.
Hi, there's a question on whether or not a C8.4 is required when paying per apportionment. The answer is no. You can just indicate that it's being paid that way on the EOR.
All right, that seems like we've gotten to the end of our questions list. So I just want to say thank you to everyone for joining us today. A recording of this webinar, as well as a copy of the presentation, will be available soon on our website and YouTube page. Please make sure you are subscribed for email updates so you'll be notified when they are available. You can sign up to receive workers' compensation news, including information on future webinars, straight to your inbox. To sign up, visit wcb.ny.gov, scroll down to the bottom of the homepage and select Get WCB Notifications. We also distribute information via our social media channels, so please follow the board on Facebook, Twitter, YouTube, and Instagram. And don't forget to visit the payer-specific webpage page on our website. Visit wcb.ny.gov and select payers on the top of the page. Finally, before you sign off, you'll be directed to take a brief survey. Your answers help us improve future webinars, so we appreciate you taking a couple minutes to respond today. Thank you again for joining us, and enjoy the rest of your afternoon.